My name is Ryan Wycliffe, and I'm a fourth-year medical student from A.T. Still University. I'll be presenting on Sturge-Weber Syndrome. A 1-year and 6-month-old male presents with history of recurrent seizures. Imaging findings on an MR-T1 weighted sequence, axial image, showed volume loss in the right frontal and parietal lobes. MR post-gadolinium T1 weighted sequences on the axial image on the left side of your screen showed prominent leptomeningeal enhancement in the patient's right cerebral hemisphere. On the axial image on the right of your screen showed enhancement and enlargement of the right choroid plexus. The coronal image on the left side of your screen showed increased leptomeningeal enhancement in the patient's right cerebral hemisphere and prominent right choroid plexus. The sagittal image on your right side of the screen showed enhancement of the patient's right choroid plexus. The patient was diagnosed with Sturge-Weber syndrome, also called encephalotrigeminal angiomatosis. This is due to sporadic error of development and is very rare. It occurs in 1 in 20,000 to 1 in 50,000 live births. It is caused by somatic mosaic mutations in the GNAQ gene. These mutations result in abnormal development of fetal capillary blood vessels. The fetal coracle veins do not coalesce and do not develop normally, resulting in persistent primitive vessels. Mutations occurring at a later stage in embryogenesis may only lead to non-syndromic port wine stains, whereas mutations occurring at an earlier stage in development may affect a greater variety of precursor cells and lead to Sturge-Weber syndrome. This results in impaired drainage and venous engorgement, and as time progresses, venous ischemia causes gliosis, atrophy, and calcification. Sturge-Weber syndrome is characterized by facial capillary malformations known as port wine stains. These occur in the distribution of the first or second division of the trigeminal nerve. They start off as flat and pink lesions in newborns, and they darken over time to port wine deep red color. Sturge-Weber syndrome is also characterized by leptomeningeal capillary venous malformation, also called leptomeningeal angioma. It affects the cerebral hemispheres in the eye, primarily parietal and occipital lobes. It's usually unilateral and often fills the subarachnoid space in the cell side. Enlarged venous structures commonly drain into the deep venous system or superficial veins. Underlying parenchyma may be atrophic with multiple calcific granular deposits. Patients with Sturge-Weber syndrome often present with seizures, which occurs in 80% of patients. These usually begin in early childhood and is often the first sign of Sturge-Weber syndrome. They're typically focal, but can be generalized tonic-clonic. Patients present with vocal neurologic deficits, and hemiparesis can occur with seizures. This is contralateral to the intracranial lesion. Up to 60% of patients present with intellectual disability, and lower outcome IQ in patients is associated with high seizure frequency, early frontal lobe involvement, or bilateral lesions. Patients can also present with visual field defects, such as homonymous hemianopia, due to leptomeningeal capillary venous malformations, which can affect the occipital lobes or optic tracts. Glaucoma occurs in up to 70% of patients and is the most common ocular abnormality. The risk is highest in patients prior to 10 years old. Other ophthalmologic findings include choroidal hemangioma, which is a capillary venous malformation of the choroid, chromia of the iris, which results in a deeply pigmented iris ipsilateral to the facial angioma, as well as episcleral and conjunctival lesions due to anomalous vessels or capillary venous malformations. In addition, patients can have growth hormone deficiency or hypothyroidism. MRI with gadolinium contrast is recommended for neuroimaging, which demonstrates the presence of the leptomeningeal capillary venous malformation and the extent of involvement with brain structures. After IV administration of contrast, the angioma appears on MRI as a leptomeningeal enhancement. However, if the patient's affected hemisphere is markedly shrunken and heavily calcified, This may not show enhancement. Contrast-enhanced MRI should be performed in all patients for whom surgery for seizure control is planned. This post-contrast axial T1 weighted image shows diffuse leptomeningeal enhancement in an enlarged right choroid plexus, seen at the black arrowhead on the patient's right. The enlarged choroid plexus is best demonstrated on contrast-enhanced T1 weighted imaging, as abnormal prominent enhancement of the choroid may be seen ipsilateral to the angioma. In addition, minimal leptomeningeal enhancement, designated by the yellow arrows in this image, is present on the patient's left frontal and occipital poles. Axial T2 weighted imaging shows atrophy and hypointense subcortical white matter signal in the left posterior frontal, parietal, and occipital lobes. The yellow arrows indicate abnormal dilated medullary veins, and the black arrowhead indicates abnormally dilated subependymal veins. The white matter underlying the angioma typically shows accentuated T2 shortening compared to the remainder of the brain, and this is likely secondary due to abnormal hypermyelination in neonates, calcification later in life, and abnormal deep venous drainage seen as flow voids. Calcifications are more readily identified on susceptibility-weighted imaging, also known as SWI, or on T2-weighted gradient echo images. SWI and T2-weighted gradient echo images are more sensitive to the difference in magnetic susceptibility between normal brain and calcium. SWI appears superior to contrast-enhanced T1 sequences in identifying enlarged transmedullary veins, abnormal periventricular veins, cortical gyriform abnormalities, and gray-white matter junction abnormalities. Axial SWI shows the diffuse hypointense cortical and subcortical calcifications posteriorly throughout the atrophic right hemisphere. The yellow arrows designate dilated hypointense medullary and subependymal veins, which are evident adjacent to the ventricle. Characteristic tram tract calcifications in the cerebral cortex underlying the PL angioma are the most frequent CT finding of Sturge-Weber disease. This axial contrast-enhanced CT at age 15 years shows extensive cortical calcification with posterior predominance, as noted by the black arrowheads. Also, the yellow arrows designate prominent and deep medullary and subependymal veins, which are faintly seen. Treatment for Sturge-Weber syndrome includes anticonvulsants for seizures. One study suggested that carbamazepine and oxcarbazepine were associated with better seizure control than levetiracetam. Surgical treatment is also recommended for patients with refractory seizures. Surgery with hemispherectomy, lobectomy, or transection of the corpus callosum is recommended for patients with Sturge-Weber syndrome and medically resistant epilepsy. This is especially recommended for patients with poor seizure control despite treatment for 6 months with a minimum of 2 anticonvulsants, and also for patients with clinically significant hemiparesis, visual field loss, and developmental delay. Low-dose aspirin may be beneficial by preventing the progression of impaired cerebral blood flow and hypoxic ischemic neuronal injury. However, no controlled studies exist. Selective photothermolysis can be utilized to treat port wine stains by using a pulse dye laser. In addition, topical medical treatments and surgery can be utilized to treat glaucoma. Neurologic function may deteriorate with age, and approximately 1/2 of affected adults are impaired. Prognosis for Sturge-Weber syndrome depends on the extent of the leptomeningeal capillary venous malformation and its effect on the perfusion of the cerebral cortex. It also depends on the severity of ocular involvement, the age of onset of seizures, and the ability to control seizures medically or surgically. And here are the references. Thank you so much for your time and attention. Hope you have a great rest of your day.